very good afternoon to each one of you. I welcome you to this special session on postgraduate training. So without wasting time, I would like to request all panelists to come to the dais. Dr. Sopan Samanta sir, Dr. Asim Kumar Ghosh sir, Dr. Chungi Swangama Miti sir, Dr. Vinita Gupta ma'am, Dr. Rajesh Joshi sir, and Dr. Colonel Avinash Misra sir. We will first finish all the presentations and then we can have the discussion in the last. राजेश सिन्हा नहीं है ना? राजेश सिन्हा सर नहीं है ना? हाँ, कोई दिक्कत नहीं. So first I would like to invite Professor Dr. Rajiv Kumar Gupta sir. He is a professor and HOD at RIU RIMS Ranchi, and he is going to give an overview of postgraduate training in ophthalmology.
Good afternoon, everyone, chairpersons, dignitaries present in the dais hall. Basically, this program is based for the postgraduate student and the training institute. The session is on teaching and evaluation of postgraduate resident, a pragmatic approach. And my topic is postgraduate training in ophthalmology in India, an overview. As you all know, the entire institution of medicine, like the institution of education, is widely seen as a public good. Medical education is therefore doubly burdened with noble responsibility. It bears this responsibility to educate well and wisely to both the student and to students' future patients whose very life might depend on it. So, to safeguard against dilution of standards, the criteria for imparting a medical education have always been stricter and more demanding than other streams. The training of postgraduate student is very critical, not only for providing quality eye care to the population, but also for the future of Indian ophthalmology. A good and proper training is required to make resident a competent ophthalmologist who could tackle ophthalmic problems independently and play an important role in elimination of blindness. There has been a definite drop in the standard of medical education in India, with only half a dozen medical institutes considered to be care of center of excellence, and even fewer central institutions where the infrastructure is adequate. This is an article on evaluation of Medical College Department of Ophthalmology in India and change following provision of modern instrumentation and training. Now, what is the current status and postgraduate training in India? Postgraduate residency program is started by taking admission in a postgraduate course either in a government medical college or a private medical college or a National Board of Examiners NBE accredited hospital. The admission is done yearly through a common entrance examination, National Eligibility Entrance Test, that is NEET, and the seat is allotted on merit cum choice basis. Duration of the course is in government and private medical college, 2 courses run, MS ophthalmology and diploma ophthalmology. MS 3-year duration and diploma 2 years duration. In NBE accredited hospital, 2 courses run, primary DNB and secondary DNB, while primary DNB is 3-year duration, secondary DNB is 2 years duration. Now, the total number of available seats, postgraduate seats in India are, in government medical college, it is 936, in private medical college, it is 509, and in NB accredited hospital, it is 205. National Medical Commission and the National Board of Examination, NB, are the regulatory authorities responsible for setting the standard for postgraduate medical education. All training institutes, with the exception of some central autonomous institutes, which are deemed universities, need an affiliation with a university for the conduct of the certifying examination for the award of postgraduate degree. NMC is responsible for conduct of NMC and DA examination, while National Board of Examination, NB, is responsible for the conduct of primary and secondary DNB examination. Medical Assessment and Rating Board is one of the wing of NMC certifying the availability of adequate infrastructure, clinical materials, and trained workforce in the training institute. Presently, postgraduate medical education is governed by MCI Postgraduate Medical Education Regulation 2000, which has the goal of producing competent ophthalmologists. So what should be the aim of postgraduate training? It should be to produce competent ophthalmologists who can independently and ethically deal with the patients in an appropriate manner. Training model should include enhancing the academic skills, giving them theoretical knowledge by lectures, either in-house faculty or guest faculties, seminars, case presentation, journal clubs, good library containing books and journals, both national and international. Clinical skill, they should be trained to do a comprehensive ocular examination with modern ophthalmic instrument, including refraction, whether passive or active, torchlight examination, slit lamp examination, applanation tonometer, gonioscopy, direct and indirect ophthalmoscopy, slit lamp microscopy. They should also be able to perform and interpret routine ophthalmical investigations, keratometry, ultrasonography, automated perimetry, optical coherence tomography, fundus photography, specular microscopy, central corneal thickness measurement, and corneal topography. Regarding surgical skill, they should be able to perform independently minor procedures and surgery like SICS, phacoemulsification, sac surgery, and trabeculotomy. To assist in squint surgery, posterior segment surgery, and keratoplasty. This is also a very important aspect of the training, that is developing research skill. Every postgraduate student at training should take up a research project. They have to write thesis. They have to present research paper or poster at conferences, whether it is state, regional, national, or international. They should publish article in journals. The present scenario, it is really intriguing to observe that after completion of residency program, a substantial number of students do fellowship program for variable periods, ranging from 3 months to 3 years. So what are the questions to be considered? Are the fresh postgraduate students not well trained and lack confidence in working outside and setting of medical college hospital? What are the challenges encountered in proper training of the residents? What is the USP of institute that offer fellowship training that attract fresh postgraduate students after completion of residency program? The challenges encountered are inadequate infrastructure. It has been observed that in majority of the training institute, the infrastructure development has not kept pace with the changing times. Absence of a standard curriculum. No standard curriculum is prescribed either by NMC or NBE for training resident, resulting in variable competencies. Deficiency of faculty and trainer who are not updating themselves in day-to-day advancement in modern-day ophthalmology. Non-availability or the non-functioning of instrument or equipment for investigation and surgery in majority of the institutes. Lack of training in various subspecialties of ophthalmology. Lack of proper and informed evaluation. There is no provision to test the quality of the training and the trainers by regulatory authorities. There is lack of opportunity. Training program of the resident is not defined and informed, so is dependent upon the faculty, especially the head of the department. Indifference of the student to learn. The aim of the present instruction course is that this course has been specifically designed with the aim to discuss the challenges encountered during postgraduate training, both for the trainer and the trainee, and the method needed to overcome these in the best possible and practical way. Now I invite Dr. Soni and Dr. Sunil, who are the other presenter, to come on the dais.
Thank you, sir. Really thank the chief instructors of this to have me here, one of whom has been my teacher, the other one my student. So, congratulations on becoming a first-year resident in ophthalmology to all my residents who have come in. What next? So maybe ophthalmology was the first choice, and we expect you to have certain qualities there. The absolute pursuit of perfection, excellence, astute observers, liking one-on-one interaction with patients, action-oriented, and a lot of other qualities that will make you innately interested in ophthalmology. But then if ophthalmology was not your first choice, so maybe you finished your MBBS 1 to N years ago, and then you gave your entrance exams with MCQs in mind, reading all subjects, and had less exposure to ophthalmology as a UG. Then you land up in some kinds of dilemmas. And what are they? They're being part of a fast-paced OPD, learning documentation and wondering when you're going to handle patients actually and directly deal with them, and then wondering what about your duration of the learning curve. You have dilemmas in OT about the variety of operations you see, about the instruments that you do not recognize, about your hand-to-eye coordination in microscopes, and operating in a limited space, and about extreme precision required, as well as the steepness of your learning curve in acquiring surgical expertise. So the duty of us teachers here are to develop interest in the students with hand-holding at every step, being patient during their initial staggering steps, and finding extra time to train them every time a new batch comes in, and forgive their early mistakes, and offer constructive criticism all the way. The most important thing here is communication for orientation of the students. So direct interaction with the new incumbents is a must. You have to ask about their background, the medical colleges, the teaching level, the confidence level in the subjects, the internship that they did in their medical colleges, and respect whatever level they are at, because it's our duty to bring them to our standards and the standards of being a good ophthalmologist. We should give them a list of what to do and spell out what not to do. And of course, a timeline of duties and responsibilities should be provided so that they know when they have to, up to what extent they have to dedicate themselves purely to documentation, when will actual surgical training, begin, and things like that. It's better to provide a structured curriculum where the importance of detailed history taking and examinations is emphasized. This is an emphasis on careful documentations of all findings, including diagrams both of the anterior and posterior segments, teaching how to use the diagnostic equipment, and special workshops on basic life support, on research methodology, on ophthalmic photography, and also attitude, ethics, and communication in ophthalmology. So we can sell ophthalmology to our residents by telling them that you are going to become a complete doctor. You're going to have medical, surgical, procedural, as well as diagnostic expertise. You may even come to a level of a radiologist or a pathologist. In addition, you'll be performing other roles as a teacher, as a team leader, as a researcher, and a lifelong learner. We have to emphasize the importance of the subject. So vision is the simplest and most effective gift that we are giving to mankind, as was spelled out by Mrs. Ashwarya in our inaugural. So we are the first to diagnose systemic diseases and malignancies, and treating children contributes to enhanced productivity of the society. We are treating population from womb to tomb, and mostly otherwise healthy individuals with minimally acutely ill patients or chronic diseases, and our conditions are rapidly treatable. Our surgeries carry, most of them, a wow effect, and with high impact on quality of life of the beneficiaries. We are involved with high-tech gadgetry, lasers, digital high-resolution imaging devices, etc., and cutting-edge research in gene therapy, stem cells, artificial intelligence, bionic eye. Really, sky is the limit. We have ample opportunities for innovations and platforms to showcase those innovations, and an industry interface to take advantage of this. And other advantages that we can be as busy as we want. There's ample remuneration for most of us. There are opportunities for philanthropy for those who would like to do that way, a good lifestyle, and a work-life balance with enough me time and family time thrown in. We are the fourth people very happy at work, as the surveys in US tell us. And then 95% of us stated that we would re-choose ophthalmology as a career. So really, it's a beautiful place to be in. Even in the Indian perspective, we have a high happiness quotient at work, at home, as well as a high career satisfaction. So we have all ample opportunities for future super specialization in the field of choice or the chapter of choice that we start getting interested in. So there's no need for trepidation here. We have to encourage our students to learn surgery. How? By encouraging them with OT etiquette, by washing them, teaching them the wash-up and gown-wearing techniques, how to know their IPD, how to use the microscope. We have to catch hold of the tremors over the tremors, the shaking hands that early residents have. And of course, we have to catch hold of those scared of doing surgery residents who refuse to wash up even for the first time. And we have to emphasize that practice makes perfect. So we have to arrange those dry labs, wet labs, simulators for them, and encourage them to attend the VAST and SSTC platforms to learn surgery. So does institute matters? Of course, we are talking about institutes of excellence and institutes not so of excellence. But honesty about the training opportunities each institute has and has not, has to be totally brought out. The extramural learning can be encouraged from lesser institutes like workshops, PG teaching programs, digital learning, etc. A self-directed learning, interactive learning, and doubt clearing has to be encouraged. We have to encourage their participation in workshops, CME presentations, with opportunities to excel with formative assessment at every step. What not to do? Definitely do not become a rogue faculty. Do not, give insulting criticism in front of patients or other faculty. We do not treat our residents as property, and we have to treat them as human beings, and do not expect no food, no water days from our residents. And doing personal work as a birthright is a definite no-no, and taking little interest in helping them choose a thesis topic or synopsis or thesis writing is not to be done. And getting branded as not to go to person is certainly a thing which we have to avoid. So the interested resident, what we get at the end of it, is a product of our mentoring and facilitation, who is grateful for the meaningful difference we've made in their lives. And the mentor in turn earns their love and respect forever, and it's totally worth it. As for the next part of my talk, when we help postgraduates choose their appropriate thesis topic, so the role of guide is, of course, that of a mentor who mentors his proteges throughout the process. The considerations to choose a topic is the student's area of special interest or a long-term career goal, or the guide's area of expertise, or common conditions encountered in the clinical setting, national priorities, impact on medical practice or policy, and the relevance to the PG program. The directions to give our students who are just going about to choose a thesis topic are to go through previous thesis of the institute, visit the institute library and use search engines, to go through previous issues of the IJO and AIOC proceedings to see what's in, access full text directly or via institute library after taking a printout of the material, and find your area of interest and look up subspecialty journals on that topic. So during the literature search, they should be asked to read at least 10 full texts on each topic of interest and focus on not only the year of publication, but also every aspect of the research methodology, especially the methodology part and the limitations. Now choosing the possible areas of the interest can be done by drawing up a list of thoughts and questions, considering current issues and opinion, leading to newer problems or changes in paradigm that we can think of. The old ones can be put in a newer context or presented as Indian or regional data, or we can identify a knowledge gap when there are not too many good studies on a particular topic, or encourage them to attend a conference or CME or interact with experts in the field of interest if possible. So deciding that type of study is important, whether trials have to be taken up, where we have to get a registry of those trials, or observational studies as are most PG topics, and prospective studies are of course better. So we can decide on the field of research, qualitative or quantitative, and draw up a finer matrix incorporating feasible, interesting, novel, ethical, and relevant, upon the shortlisted topics, and then elaborate further the shortlisted topics on every aspect to find out another finer matrix that will tell us ultimately a topic which is acceptable to both. And then, of course, the cardinal rule is not to bite off more than you can chew. So to do this, you have to match the research question you arrive at with the study design. You have to draw up a proper hypothesis for this. And then you have to calculate a sample size so that you do not land up with a sample you cannot fulfill at the end of your thesis. And then you have to frame your study objectives, both primary objective as well as a secondary objective. And so that ultimately you can sit and actually write down your topic by this acronym of PICOT, Population, Intervention, Comparison, Outcome, and Time, which is written for the primary objective in a precise, concise, and informative manner regarding the time, place, person, exposure, outcome, and study design. Now, this is an example of this. This is a topic which really conforms to PICOT, but however is a little bit too complex. This is one of the topics which has won ARC award. And then, of course, to conclude, well begun is half done. So good work helps you publish in a reputed journal and become eligible for the ARC PG Thesis Young Researchers Award of the AIOC. And it's the first step to empower our students to guide someone else for a research later on in their life. So we have heavy responsibility here, and our enthusiasm of both the student and our mentors will lead to the best outcomes for our postgraduates, irrespective of whichever institution they belong to. So thank you for your patient hearing.
Thank you, ma'am, for your wonderful presentation, as always. Now I request Dr. Sunil Kumar sir to present his topic. He's an associate professor at RIO, Rajendra Institute of Medical Sciences, Ranchi, and he will be talking about how to teach and enhance academic, clinical, and surgical skills.
Thank you. So very good afternoon, everyone. So the topic assigned to me is the teaching and enhancing the academic, clinical, and surgical skills. So I have no financial interest in any of the subject matter mentioned in my presentations. So the residency training is one of the most crucial phases in the medical career. It transforms the theoretical generalist, that is the MBBS, to a practical specialist, that is the MS ophthalmology in our case, who is geared up to take the responsibility of the caring for the patients. And so the acquisition of the knowledge and development of the necessary clinical and surgical skills is the prerequisite for providing the optimum care to the patients. So I have basically divided into three groups. PG training, the one is the academic, next is clinical and surgical skills. So coming to the academics, what is the most important? For the first year, for all the residents, you must make the habits of the reading books and journals. And it is not the one day, it is a daily effort which is required. You must read something every day. And if any interesting case you saw in the clinics or in the OPD, suppose you saw a patient of the Fuchs-Beatty syndrome, your senior or faculty might have made the diagnosis. So when you go back and so you read from the standard textbooks and match your findings with what is given in the books. And next day you can discuss again with your seniors. So in this way you will learn for a longer period of times. So the next question which comes to mind, especially for the first year resident, is which books to read. So in my opinion, don't restrict your readings. Your seniors or colleagues may comment like, "Arey, wo kyun padh rahe ho? Ye tum Ryan kyun padh rahe ho? Tumhe to Kansky padhna chahiye tha." But this is not like that. Believe me, you are allowed to do the wide readings. Any book which you like Ryan, Sild, Kretschmer, Jakovic, any book you should read. Why I'm telling that? Because in these books, the sentences or paragraphs are written in such a manner that you can retain more. So what are the basic reference book which you must read? In my opinion, the Kansky's Clinical Ophthalmology, the beautiful images are given for all the topics and all the chapters, and also the books from the American Academy of Ophthalmology, that is a basic and clinical science course, that is the 13 volumes, very concise book. You must have all these books. And also the Albert Jacobi, the Principle and Practice of Ophthalmology. I don't have any financial interest related to any of these books, but these are basic for the residency. Then there are also the specialty books, like the Retina, the Ryan's, Cornea by the Kretschmer, Smolins, Steinert, Cataract Surgery, Sill textbook of Glaucoma, Dredge of the orbit by Rootmans. Very beautiful differential diagnosis is given about the orbital tumors in these books. Also the strabismus by the Von Neudens and the refraction. I'm not saying that everyone has to read these books from the first page to the last page, but especially the common things you saw in the clinics or for the case presentation or seminar, you have to take the reference from these specialty books. Then there are hundreds of journals available, but for the resident, you must read the survey of ophthalmology, especially when you are making the seminar presentations. There are beautiful review articles are given from where you can get from the starting from the historical perspective to the current advances they are given. Also the current opinion of ophthalmology, the recent advances given. You can also take the reference from these journals. Now coming to the attending the lectures and seminars. So every teaching institute has their fixed seminar lectures, but coming blank to the class is a crime. So every resident who is coming to the class, you must read in advance. Because you know the teaching schedule and know the topic at least a week in advance. So you must read from their standard textbook. Make your own notes. And when you come to the class, not forget to ask the question. Also become the part of the discussion. So in this way, you will gain more. Also they're coming to the case presentation or the ward round. So in the case presentation or ward round, a resident doctor presents a patient history and examination before a faculty in the presence of the other residents. And the discussion regarding the lacuna in the history taking, examination, and possible investigation and management that follows the presentation is most rewarding. So always be active or always participate in this ward round. Whether you are correct or not, it doesn't matter. Always try to ask the question, why this investigation is done, why we are giving this treatment, why not that treatment. You should always discuss. There are also various PG teaching programs. Even the AIOC is the pre-conference PG teaching program, ISALA. The ARCs and pharma sponsored by the iFocus, by the CFS groups, IPAY by the LBPI. Even the various state society run their own PG teaching programs. So you must attend at least one of these programs. There are various online resources also available like ONE network. If you are a member of the iOS, you can get access to this network. Also like helio.com, iWiki or BS eOpta to mention some of these. And also the various lectures, beautiful YouTube channels are there. So you can have access to this. Now the next part is the coming to the clinical skills. So again for the clinical skill develop, daily effort and hard work is required. And you must make the habit of the comprehensive eye examination. No matter what the patient has come, even suppose the patient has come for the just for the presbyopic correction, you should make the habit of the comprehensive examination like visual acuity, Goldman applanation tonometry, slit lamp, 90-degree examination. At least you try to see the disc and macula. So in this way, you will not miss the important diagnosis. Also, you have to do the indirect ophthalmoscopy and gonioscopy in selected cases. And also the investment. For the first year, you must purchase your own lenses on good quality lenses like from the bulk. I don't have any financial interest, but these lenses is worth of their price. Also, you should have your own direct ophthalmoscope, gonio lenses, retinoscope, so you can make more use of that. Now coming to the slit lamp examination. You must do the slit lamp examination with the proper technique. I am not going to detail about these things because this is out of the scope of this, my presentation, but you must do the systematic manner like diffuse examination to see the gross abnormality, lead and extra examination, then focal examination, retroillumination, sclerotic scatter, specular refraction, etc. And you also must do the staining pattern and make its interpretations. Then fundus evaluation, especially if you are in the retina clinics, do the direct ophthalmoscopy, indirect ophthalmoscopy with the proper indentation, and make the habit of the proper fundus drawing in the proper Amsler-Dubois chart. And also you can do the 90-degree examination with the both dilated and undilated pupils. Similarly, the tonometry you have to do in each and every patient, and gonioscopy in certain patient, you must learn the practice. At least you have to do the one gonioscopy per day. That's why you can make the identify the angle structure, grading of the angle, and especially if there is any abnormal pigmentation or synechia, you can make out. Now the refraction. Nowadays, many residents are reluctant to do the refraction, but in my opinion, refraction is one of the most important part of the PG training. You must learn the art of the retinoscopy, use of the Jackson cross cylinder, and also how to prescribe the glasses. Then biometry. Biometry, all the residents must do with their own. Like keratometry, manual keratometry, must learn AS scan, the immersion on contact method, and also you should get acquainted with the various formulas of the. You just not do that like the technician. You have to assess the various formulas. What is the axial length, what is the which is matching with our AC depth or not, what is the lens thickness, and whether the IOL formula is matching with our preoperative refraction or not, and what are the different formulas which you are using, you must all be acquainted. And you can discuss with your seniors or even your teachers. Then there are various investigative modalities which are in some of you maybe in your departments, like fundus photography, fluorescence angiography, OCT, UBM, ophthalmic ultrasound, automated perimetry. So you must be able to interpret all the findings of these machines. Now, the next part is the surgical skills. So the beauty of the ophthalmology is the sight restorative microsurgery. But this surgery requires lots of practice, hand-eye coordination and ambidextrity. Ambidextrity is very important. And also, you should get acquainted with the function of the microscope, like what is the zoom function, fine focus, centration, IPD setup. So before starting the regular surgery, real surgery, you have to get acquainted with all these functions of the foot switch. Now, suturing. Suturing is again the vital ingredient of the ocular surgery, and it should be encouraged to the resident. They could start suturing on anything like thermocol, banana. You can practice apple or even orange, because this will help the trainee to develop good hand-eye coordination and also teaches the ambidextrity under the microscope. Now, for the first year, there are various minor surgical procedures which are specifically done by the first year. So you must learn like conjunctival and corneal foreign body removal on the slit lamp, syringing, probing, collagen incision. But you must learn the proper technique from your seniors. Biopsy of the small lid tumor, suture removal, tarsorrhaphy, subconjunctival injection, retrobulbar, peribulbar anesthesia, PST injection, artificial eye fitting, or evisceration like that. Now, coming to the major surgery training, there are various phases. In the first phase, generally, or the first year, the PG student is given the training in the preparation of the cases for operation, pre-medication and the regional blocks. In the next phase, the PG student assists the operating surgeon during the operation. And in the third phase, the PG students operate independently, assisted by the senior residents or the faculty members. So the wet lab training. Wet lab actually is the building block of the surgeon's skill. It is an indispensable component in the armamentarium of the teaching hospital. It helps the trainee to develop the skill in a risk-free environment. So what we can do practice in the wet lab, like suturing with the 10-0 nylon in the thermocol or animal cadaveric eyes. We can practice the making the sclerocorneal tunnel in animal eyes. Even the practice the capsulorhexis in the goats or animal eyes. Use of the Simcoe cannula to aspirate the OVD after injection in animal eyes. We can use the goat's eye for doing phacoemulsification also, or the various wax model is also available, like from the Madhu instrument, eye phaco is there. Also, you can practice the placing the foldable or rigid IOL in the animal eye. And even the automated anterior vitrectomy can be practiced in the animal eyes. Now, coming to the complication during training surgery. Remember, even the best of the surgeons today have made some mistakes while learning. However, since we are dealing with the human eyes, we cannot afford to make too many mistakes. Whenever a mistake is made, read up and discuss with seniors about it so that it is not repeated. So it is all right to make a few mistakes, but it is unacceptable not to learn from them. It may be helpful to record each and every steps of the surgery and review surgical videos in consultation with your senior in case of any complication. And finally, do not worry about the time taken during the initial surgery. Speed is never as important as the safety. So to conclude, the daily efforts, hard working and sincerity is what is required from the resident side, and practice to require the clinical and surgical skills. And of course, the good teachers and mentors is required for your proper training. Thank you very much.
Thank you, sir, for the wonderful presentation. Now we have with us Professor Rajiv sir, who needs no introduction. He's a professor at RP Center for Ophthalmic Sciences, AIMS, New Delhi. And he will going to talk about how to write scientific paper and inculcate research habits among residents. It's the keynote address. He will deliver the keynote address.
Thank you, sir, for the opportunity, and I would like to thank Dr. Gupta for inviting me in this wonderful, interesting session. I'll be talking about how to write scientific paper and inculcate research acumen in residents. So the question is why we should publish, why there is so much of hue and cry that we should publish. If at all we are doing any study, I mean, no scientific experiment can be considered completed or can be considered yours unless you publish it in your name. So that is the key. That's the reason why we should publish. And when we are publishing, this is the format that is commonly used, like this is the IMRAD format, like first you write the introduction, methods, results, and discussion. And these are the components, like you first write the title, then you have the authors, the abstract, then you have the keywords, then you write introduction, methods, results, discussion, and then acknowledgements, and then references, and then of course you have some appendices. So before writing any article, you have to understand what should be the format of the manuscript. And for that, you have to go through the author's guidelines of a particular journal. The title is the most important thing. Why? Because that is the show, that is the, people say that if there's a catchy headline, people like to read the details of what is written under the headline. And that is why title is very, very important, and that should be meaningful, and that should be conveying some message that what exactly is the study. It's actually the advertisement of your article. And when you are preparing a title, you should think about some keywords, and then you can incorporate in that. And ideally, it should not be more than 12 words, and it should be less than 100 characters. And you should not write any abbreviation or any proprietary name or any trade name, etc. in the article. So that is something which is very important. Then as far as authorship is concerned, all the people who have performed the study should be a part of that study. And suppose it's a thesis that is being done, unless there is some definite reason, the candidate who is a part of the thesis and has done meaningful exercise in that, his name should be first, and then of course the co-instructors, the guides, and all those names should be there. And all this order has to be discussed amongst all the co-authors. Now coming to the abstract of the article, abstract should best be written after you have completely written the article. Once you have written the article, you exactly know what is the gist of that manuscript, and then you can better write the abstract, which will have its impact. And it depends on the type of manuscript that you are writing. If say technique and you are writing a summary, it is in 150 words. If it is a structured format of purpose, methods, results, and conclusion, then mostly, in most of the journals, it is in 250 words. So that gives you, the abstract gives you an idea, a summary of of the manuscript. And it is always written in the past tense, and it refers to the work that you have done, and it should not have references, etc., no figure quoted in that. Then you come to the manuscript per se. When you are writing the introduction, that is the first and foremost thing. So you should write, where are we at this point of time? Like in a particular scenario, we have to give the background information, that where do we stand in the current literature, in the current scenario, in the current scientific standing, in that particular topic, what all we know. And then in the last line of the introduction, you should write that what are we aiming for and what new thing that we are aiming for in this study. So that is something which should be written in the introduction. And you should always write the research question in that what is your research question, what exactly you are hypothesizing. So all these things should be written in introduction. Now coming to the materials and methods, you should be absolutely complete. It should be comprehensive. It should include the subjects. It should include whether it's a human study, an animal study, and then what is the methodology. And it should be written in such a way that the reader can read and understand and can reproduce in his own setting. So methodology is the key that will send the information to the readers that this is the way it should be done, and this is the way how you can replicate in your own setting. And of course, you have to explain all the methodology in great details, and you have to write about the number of individuals, whether this sample size is adequate or not. So why you considered this sample size, what was the reason for the sample size. So all these things have to be written. Now, once you have done the study, then you start thinking about the results. And results should be written thoroughly. There can be headings, subheadings, like demographic data, then related to visual outcome, related to comfort, related. So you can have subheadings in the results, and you should write all the data. And it should again be written in past tense, because obviously you have done the study and this is the data that you have got. So you should write the data, and no interpretation should be written in results. That is very important. And if there is too much of data for a particular point, then you can make a table of that. And that should not be duplicated in the result section. And again, if there is some trend that you are showing, something, some linear correlation or a trend of change of any outcome values, then the trend can best be shown by figures, because that will depict the actual change with time. And as I said, the tables and figures are the ones wherein you put in data which are not there in the results. You can refer in the results that refer table 1 or table 2 or figure 1, figure 2, but that should not be, the same thing should not be written in the results. And also sometimes what people do that they have a table of certain data and they make a figure as well of that. There's no need for that. If you have written a table, there's no need for figure of that. Then coming to discussion, which is of course the hardest, most difficult part to write, because you have to understand your own outcome, the outcome of your own study. Then you have to go through the outcome of different relevant studies. And then you have to compare and say that how different you have, what different is your data. It may not be different, it may be same. Then you can also say that, okay, there is no difference. There can be some negative information. There can be something that it is not helpful. So that also should be written, because many times, say some procedure which is not, you have done in 10 eyes and all the eyes, that procedure failed, then that can have people may say that the procedure has not yielded any result. No, it has yielded a result. It has shown that this procedure is not helpful in that particular condition. So this is all interpretation that you have to do after studying your own data and after studying data of other studies. So in the first paragraph, you state the major findings, and then in the middle paragraph, you focus on your result and then discuss, and the last part, you write the conclusion. And the biggest mistake that people do is that the extrapolation of result in a different way in conclusion. Like suppose 10 patients had undergone some procedure, say a glaucoma procedure. There was a reduction in some amount of IOP. So you can say that this procedure in this set of this cohort of patients can do this. You cannot extrapolate to all the cohort, to all the population, to all age group. So you have to be very specific in your conclusion, and there shouldn't be any unnecessary extrapolation. Then as far as acknowledgement is concerned, you have to acknowledge people like your technicians, people who have helped you in doing the study. So acknowledgement is something which is again very useful. And referencing is the standard way of referencing is the Vancouver method, but then there are other methods as well, like Harvard format, then alphabet number system, and citation order system. So all these are different methods, but most often it is a Vancouver system that is followed, and the citation method, like the number 1 reference, will come first in the manuscript. So this is how in most of the journals they do, but in some journals they do it as alphabet as well. And a very important point is that one should not put their own personal gut feeling in the manuscript, that and don't write any quote related to that. We have to be absolutely scientific. There's no place of literature in that. That is the most important thing. And all the authors have to read and proofread the manuscript in order to have the approval of all the authors. So this was briefly about how we should write a manuscript. Now the question is that how we can inculcate this research acumen in residents. Any institution cannot succeed in having a good academic strength unless all the three tier of the institution takes part in the research activity, like the consultants, the registrar level, and the postgraduate level. So these are the three-tier system that works in most of the institutions. So everybody has to participate in research, and that is why we have to inculcate research activity. And these are the key elements of any residency program, and the concept of research activity has to be inculcated. Now, there's point that why it should be inculcated, why it is important, because these days it is a competitive world and things are changing. We have to learn this thing. Now, even at small places, even in small institutions, there are many people who are doing studies, who are reporting. And if you don't do that, then you will lag behind amongst your peers. So that is a very important thing. You have to compete and you have to be at par with your peers in order to do that. And you have to be a better doctor, because the resident, if he thinks about the methodology, or maybe the teacher suggests that this should be the methodology, and he reads it, he goes through it, then he will understand that, okay, for this particular study, this is the methodology that should be followed. And if he reads the conclusion, he will understand that, okay, this was the finding, and the conclusion is this, so it should be written like that. So his thinking changes, his thinking becomes more scientific, and that is what we have to do. The thinking of every resident has to change. They have to think about, how research can be done. Research doesn't mean working at the molecular level. Research is something that you have to keep your minds open, that what is known in literature and what new thing you are observing in this particular condition, in this particular case. And if you report that, then that will help other people to become more, better clinician. Like, for example, there's so many articles on post-classic keratitis and what are the microorganisms that are involved in that. Oh, why do we have to know all that? The reason is this, that if we get a case of post-classic keratitis, then at that point of time, you will investigate for those organisms. That is the key. So that makes you a better doctor as well, a better clinician as well. But then this survey, this was done, and this was a survey done for looking for the reasons why residents are not involved in research activity at various places. And they found out that the lack of time was cited as an obstacle for research by 74% of residents, of which 66% felt that training in their specialty consumed most of the time, and 42% admitted lack of research curriculum as an obstacle. So that is something that, even at the level of various institutions, at the level of MCI, at the level of DNB, things have to be done in such a way. And even in the interviews for senior residency, it is always asked that, have you published any paper or not? Have you done any research or not? So this is that we have to inculcate in them, that time management is the key. The person who manages his or her time in the best possible way succeeds in life, because everybody gets these 24 hours only. So you have to manage your time in such a way, and that is something we have to encourage them, that whenever you get even half an hour time, instead of just gossiping in the ward, or instead of just hanging around somewhere, do something related to research. How you can do it? You can make a curriculum, you can sensitize them, you can tell them the importance, you can cite examples of the peers who have done well, the seniors who are so well known in the field, in this field. Why they are known? Because they have done this research activity. And once again, I will tell that research doesn't always mean that you have to work at the molecular level. Research also means there's a clinical research, so that element is also there. So how will you start? You have to think broad first. The first thing that I would ask my resident is, whenever a resident comes to me and asks me for the thesis topic, I will tell the resident that, okay, this will be a broad topic, and you just have to think like suppose phakic implants, I will say that, okay, you have to think about the factors related to vaulting and go and do literature search. So the first thing that a resident should do is literature search, because that will give them the idea that what all has been done in this world, what all has been done in this particular field, in this area. So literature search should be done, and then of course we have to discuss with them that what do you think, what has been done, and what more needs to be done, what are the problems. So that is something we have to tell them. And the second important thing is that once they have done the study, then they have done the study under the guidance of some seniors. So we have to tell them that what exactly has been done. You have to put it in Excel sheet, and now you have to think about how to write the manuscript, how to analyze it. Little bit of biostatistics, little bit of information about how we can write the manuscript. And of course, we all have to create in various institutions the workplace environment wherein, the residents should have access to all these facilities related to computer and internet so that they can keep working. And we have to provide them educational supplies in terms of journals, in terms of online journals or physical journals. So these are things. And another thing is that we should always, in order to inculcate research activity, we should always have a journal club in all our institutions. That is very important, because you can review some article and then you can tell us that what is plus point of this article, and try to figure out what is the lacunae in that article, and that will inculcate that thinking skill amongst the residents. That's the most important thing. And of course, funding and etc. has to be done by the senior member of the organization. So thank you very much for your patient listening, and would definitely like to have inputs from you all.
Thank you, sir. First, I would like to thank you for accepting my invitation to present your keynote address. Thank you, sir.
Okay.
And thanks you also for sparing your valuable time for this keynote address. Thank you, sir.
Thank you. Thank you, sir.
Now I invite Dr. Deepak Misra to give his presentation. Dr. Deepak Misra is from Institute of Medical Science, BHU. He will present his paper.
It's already opening. Thank you, Professor Gupta, sir. Respected teachers on the dais and off the dais, first of all, my gratitude to you and dear residents. Sir has given me a topic for what is the evaluation pattern for the postgraduate teaching. There is no financial interest, of course, in such topic. I have divided my topic into 3-4 parts. Means before, when a resident should move other side of the dais, he must know what is expected from him or her to be as a part of preparation, as anything to move towards the going for the examination. And then we have 3 types of courses running in the India. One is the by MCI, MS or MS in ophthalmology. Previously there was DO by MCI, but it is now under the NB National Board of Examination and Dnb Ophthalmology. All have basically the same pattern and everything, but there is slight changes in the evaluation pattern and their guidelines where what two residents should know. But this teaching learning modules, everyone know. So whatever is the theoretical, and all the evaluation will be done on 2 types. One is the part of the theory and another is the part of practical. I am not going in detail of this, but at least we know that evaluation or the evaluation pattern move for the both clinical and theoretical. And what are the knowledge everyone what we want to know, what is essential for the skill. First of all, moving towards the skill as a resident, as first year resident, second year resident, they want to know sir, what we know, what is expected from us during examination. There is lot of view because in MBBS there is a less time for the ophthalmology and exposure to ophthalmology is very less. I can still say, if my teachers agree, that MBBS graduate at our place is not so well known for the ophthalmology. They know that their ophthalmology is a subject and it is a small subject. They didn't know that ophthalmology is so big and have lots of subspecialty in it. So at least I can suggest them that you should know the slit lamp examination, fundus examination, direct charting, all these things are covered. So I'm not going in detail, just mentioning that these are the things which is expected from a resident to pass this evaluation system. And refraction is one thing I would like to add. Nowadays, if we ask any resident to do refraction, he or she behave like that is a crime. But we all know that refraction is the only thing which gives you a make you much more competent ophthalmologist instead of learning higher whatever the skill modalities or the newer gadgets you have. But there is no substitute of refraction in the clinical teaching and evaluation both. So my request to all residents, never took it very easy that we can do it. Refraction is a learned skill. You have to do daily 1 or 2 refraction, and unless until you know the proper refraction, you will not pass your MD or MS examination. Investigations. Whatever the investigations is required, usually we are knowing all of them investigations, which are mostly nowadays all the investigations are gadget based except the slit lamp examination, direct and indirect. So at least you know how to read the printout of Humphrey, how to explain the FFA. These things are expected. And there are n number of minor and major surgical procedures. I'm not going to elaborate in this because these surgical procedures anyone can ask you. It depends upon what is your case and what the expert want to listen from you. So, but some procedures is very much important. Like I am giving one example. If you having a case of glaucoma, then at least know that whenever there is a surgical part, then know the trabeculectomy, whichever surgery or the treatment modality is common for which disease. If any corneal condition if required, and at least know PK. If you're not knowing lot of advances or everything, still, but whatever is the basic 1 or 2 surgeries, just like a broad line. If we are going for a case of glaucoma, then at least know trabeculectomy, at least know what is the anti-glaucoma drug and what are the laser procedure. These 3 basic things you have to know. So don't go in detail or whatever the rare thing, but at least most important is evaluation is done on the common questions, and all the teachers agree that mostly they will do the common questions. Now coming to the postgraduate examination pattern in India. One of the important thing is the thesis. Always remember that none of the institution or university allow you to appear in the theory exam if your thesis is not accepted. So acceptance of thesis is very much important. Don't take it lightly. So do and submit your thesis on a proper time. Unless your thesis is accepted, you will not allowed to appear in exam. They will not release your admit card. And in DNB, even they can, after passing your theory exam, they can withhold your result. Second thing is the theory papers. These are the 4 common pattern of the theory paper. Usually in all the universities of the India, they have paper 1, 2, 3, 4, and one is basically on the basic sciences or the anatomy and physiology. Clinical 2, paper 2 is on the clinical. Paper 3 usually the surgical complications and the related topic, and paper 4 is the recent advances. This is a broader classification. Sometimes in paper you may have mixing or something interchange, but this is the proper what we got it for making question paper from examinations. There is a guideline that you have to make paper 1 for this, paper 2 for 3. For the practicals, always you have different kind of cases. There will be a long case, short cases, fundus. Again, I am telling you fundus and refraction is important, and there will be a set of this examination. Instrument table will be there, X-ray will be there, and they may have some diagnostic techniques. There will printout of fields, whatever the things are available for your clinical skill I've just told. So practical consists of long cases, short cases, instrument viva, some diagnostic fields are the printout will be there, and you have to know at least go for the 6-7 stations are there. It may depends upon either examiners divide 2-3 stations with each other and share the same. Now the postgraduate teaching for the DNB courses. There will be two type of courses at present in the DNB. One is the primary DNB for 3 years, and secondary DNB who have already did DO can go for the 2 years. And again for the DO there will be a scheme of the pattern for the DNB. DNB examination is slightly different from the MS, and their evaluation is slightly different. For the MS you have to go for the theory examination and practical, and result will be declared simultaneously. There will be no issue of that. But in DNB you have to pass in theory first, then only you will be allowed to appear in the practicals. That is a major difference. So once you have to pass your theory examination, then only you can go for the practical. And the theory examination, DNB in MS, there will be a both having 100 marks paper, but there is difference. In MS you may get a question of 30 marks and 40 marks, like anatomy of orbital cellulitis and orbital spaces and cellulitis, 30 marks in MD. But in DNB it is not like that. They have structured it in a such a way that each question paper have 10 questions and each will having 10 marks each. So it will appears that it is slightly lengthy process to write 10 questions in each, but it is uniform and fixed that in each DNB paper you will get 10 questions. In MS and DO you may get 5 questions, 4 questions. It depends upon how in part 1 and part B your examiner decided. Second thing, time allotted to both courses is 3 hours, and here at least 50% aggregate marks is necessary to pass the theory. Same is in the MS pattern. But again I am telling you that these division for the MS and DNB for the paper wise is same. There is no difference in that. But there is difference in the practical examination. In the practical examination of MS I have already mentioned long cases, short cases. Everything is here too. But there is difference that they have now, previously the OSCE was not there, but after the COVID and due to COVID, there is a pattern that out of 300 marks, they have given 100 marks of OSCEs. OSCEs are the long questions based on the photo scenario, case scenario, some surgical video, and they will ask you 3-4 questions. And rest 300 marks can be divided into different clinical patterns. And when anyone can pass the theory examination, they will allow only 3 attempts for the practical in the DNB. If you, and first attempt is mandatory. Anyone even left the examination or unable to attend the examination, they will treat as your attempt for the first time, and the rest 2 times you have to pay the DNB board and examination fee and appear for that. Most important is that if anyone cannot get the passing marks in 3 attempts, then again he or she has to go for the theory examination, and then he or she will appear in the examination. That is the difference between MS and DNB. In MS, if you pass the theory examination and if somehow there is some less marks or not able to pass, then you can give it in 4 or 6 months, but there is nothing like that. They give you 2-3 attempts. In your supply exam 2, again you have to give theory and practical both simultaneously. For the DO courses having 1 year less teaching and syllabus is almost same, but only difference is that in their theory they have only 3 papers instead of 4 papers, and there is no requirement of writing thesis. Thesis is mandatory for MS and DNB, but not for DO. Here duration is 1 year less, 1 paper is less, and thesis is not required. But still I am saying the whole examination pattern is almost same. Either DO, DNB or MS, you have to know what are the basic things required from you, and you have to know. Now coming to my conclusion, evaluation for any postgraduate course depend in all the 3 courses based on the theory and the practical both. And I suggest all the residents that preparation should start from day one of the residency. It is not like that you can, I will read in last 3 hours or last 4, because it is both. Someone can do better if he or she sit 12 hours in a day for last 5 days in theory. But in the practical, and it's two-way communication. The person in front of you is having 30 years of experience and doing lot of things. You cannot fool him by making 2 or 3 days. Even you start speaking, he understand what you have done in your practical or not. So for these practical examinations, since it is a mandatory part combined with your training, it is important to start your preparation for the practical and do the practical clinics from the day one of the residency. And one thing again is important, always know the guidelines and examination pattern by your university. Many of the universities have some guideline that you have to submit thesis 6 months, someone saying 3 months, NBEC saying 6 months. At least you know when you have to submit thesis, what is the question pattern of your college, and what is the examination pattern. Because in the last moment, if someone get that, oh, I am not knowing that the thesis has to be submitted 6 months before or like that, then there will be a problem for you. With this note, thank you all and regards to my teachers.
Thank you, Dr. Deepak Misra, for a beautiful presentation. Now I request the last presenter, Dr. M. Shiraz Ali from Ranchi, will talk on future perspective and recommendation for improving quality of postgraduate training. Dr. Shiraz.
Thank you, sir. A very good afternoon to each one of you again. The aim of medical education is to produce doctors who will promote the health of all people, and that aim is not being realized in many places, despite the enormous progress that has been made in the biomedical sciences. This article by our own AIOS stalwarts presents the feedback of training of those who were trained in the last decades of the 20th century and compares it with the feedback of training imparted in the first decade of the 21st century. Almost all clinical skills, teaching, and exposure to investigations had improved over the past decade. The 20th century trained cohort reported only refraction, diplopia charting, synaptophore as being taught better than the 21st century cohort. It was also found that in the present scenario, both independent and surgeries performed under supervision were less. Exposure to cataract surgery was adequate but not uniform, and SICS was the most common cataract surgery taught. The median for strabismus surgeries, RD surgery, vitrectomy, and keratoplasty was 0. Glaucoma surgeries, pterygium excision, sac surgeries, and eyelid surgeries had declined in number in residency training. So numerous educationists and academicians have recommended varied strategies for improving the quality of residency program in India. The shortage of medical teachers in higher education is because only those teachers defined as per NMC and NBA guidelines are recognized to train specialists, and their numbers are quite limited. There are a number of well-qualified and competent specialists, including in the private sector, as well as in the public sector hospitals like railways and defense, who could be considered teachers. Creation of an appropriate body like a teacher's accreditation cell could ensure continued evaluation of the teaching outcomes and maintain quality through recertification and continuous professional development programs. There should be adaptation of a standard common curriculum across all medical colleges in India. Curriculum is a dynamic and flexible document which should be responsive to the changing needs of the functions that a doctor has to perform in his or her community. It has been recommended that the postgraduate residency program should start with an induction training of at least 2 weeks, so as to sensitize the students to the versatility of the field of ophthalmology, and also it will familiarize the student to the institute and to the various departments. There is a need for formulating a manual which would explain the course objectives and the term-wise curriculum provide guidelines to proceed throughout the course. And this will also tell the students what is expected of them at the end of each term and at the end of completion of the course. There should be a good learning resource center, including a good library, and acquiring administrative skills is another important part of training. Competency-based teaching has been applied to undergraduate medical education in India in 2019 and recently been applied to postgraduate training also. So this type of training focuses on the development of competencies required to fulfill a patient's needs in real life situation. And this type of learning focuses on the continued training of the student until the competency is achieved. This editorial published in IGO, here the author has suggested the incorporation of the 6 ACGME competencies into the residency program. The COVID-19 pandemic has shown that technology can be used across all the healthcare sectors. A course on technology should be incorporated into the curriculum so that the students are up to date and can apply it in their clinical practice. A course on available technologies like robotics and artificial intelligence should form part of the curriculum, and a distance learning mode should also be incorporated. The COVID-19 pandemic has also has led to a wider use of virtual learning across all academic sectors, including medicine. Although it requires resources, this benefits students because they can learn and relearn at their own pace, at their own convenience, and at their own convenient work or study location. And these lectures become increasingly powerful when used with the flipped classroom model, an effective strategy that is widely used in the Western countries. Virtual learning also includes use of interactive technologies like polling features and gamification strategies, which increase the student engagement. Simulation-based studies have been quite popular in the Western countries and are revolutionizing the medical teaching. Simulation-based studies can help in early acquisition of complex clinical skills, increase the importance of patient safety, and reduce patient dissatisfaction as being practiced on. So the students should be told time and again that the number of cases doesn't matter. Doing with good understanding is more important. The flipped classroom model is a type of instructional strategy and a kind of blended learning which aim to increase student engagement and learning by having the students complete their readings at home or at their hostels and work on live problem solving during class time. To reduce the number of students, which is one of the causes of lower standards in medical colleges in India, it has been suggested that medical colleges be broken into satellite campus or new campuses. This will also upgrade the health services of a neglected geographical area. There is inability of fresh postgraduate students to work outside the setting of a large hospital where there are no sophisticated diagnostic and treatment facilities. Since majority of the postgraduates will practice outside the setting of medical college hospitals, a major part of their training should also be in settings outside the medical college hospitals. Trainees should be assigned to a chief mentor and also to other mentors also for overall personality development. And trainees should be provided opportunity to undergo short exchange periods by way of externships at institutes of excellence. So the medical education system needs to empower the trainees to learn and practice in line with geographic, socio-cultural, economic, technological, and behavioral patterns. Interprofessional education is another practice educational strategy which often combines with medical students with members of other healthcare disciplines, including but not limited to students and faculty of other specialties, nurses, nursing students, social workers, pharmacists, clinical laboratory technicians, and administrators. Traditional medical teaching imparts theoretical and practical knowledge of diseases and their management, but soft skills like professionalism, ethics, and communication are not formally taught. A training in soft skills should form part of the curriculum. This article was published in IGO by Dr. Purvi Bhagat Madam and all. She's here. And the purpose of this study was to assess the need for teaching communication skills to ophthalmology PG students and develop and introduce a module for the same. In this study, 99% faculty agreed that learning communication skills can be helpful in professional and personal life. 96.3% faculty opined that students make matter worse while trying to resolve a conflict with a patient, and 74.1% faculty found an increase in incidence of complaints arising due to patient dissatisfaction because of poor communication with them. Presently, the research endeavors for the patients act only as a permit to appear in the examination. The focus of the postgraduate students lies just only in the completion of the research project rather than on the core issue, its impact, its value. Thesis has its value when published in a scientific journal and add to the global pool of knowledge. Weightage in the final assessment should be given to attending conferences and presenting papers in conferences, and this will motivate students to undertake short clinical activities and thereby improve their their skills in the research domain. Travel grants should be provided to students to attend international conferences to get good orientation to quality research, and medical colleges should be attached to institutes of excellence for doctorates in medical research to avail of the high caliber guidance and infrastructure. Feedback from all stakeholders should be obtained on a continuous basis to keep abreast of the recent advances and to maintain quality. Learning is incomplete without assessment. A 360-degree assessment must encompass personal attributes, didactic knowledge, clinical skills, surgical skills, and academic performance. So this review article was very recently published in IGO, and in this review article, the authors have suggested a variety of tools that assess the diverse skills that a resident is expected to acquire during his or her residency. Presently, the current system of final assessment based on theoretical and practical knowledge does not give an overall view of the performance of the student through 2 years or 3 years. In addition to the final university examination, weightage should be given to the overall performance of the student through 2 years or 3 years, and this should be periodically assessed. Certification incorporating profession-driven standards and requirements should be granted to those who meet a series of accredited medical training requirements and complete intensive evaluation process. So to conclude, residents should have a purpose in joining a residency program other than just acquiring a degree, being part of a larger mission. Change is never easy. Change is always resisted by those in the existing system. Reforms of medical education requires more than agreement. It requires a widespread commitment to action, vigorous leadership, and political will. The National Medical Commission came into force on 25th September 2020. This historic reform will steer the direction of medical education towards a transparent, qualitative, and accountable system. Thank you for the patient hearing.
Thank you, Dr. Shiraz, for your good presentation. Now, I request my panelists, firstly, Dr. Saban Samanta, Professor Ophthalmology, to give his view for improving the postgraduate education in our country.
Thanks, Professor Rajiv Gupta bhai. But I think time is over. Thanks, Professor Rajiv Gupta bhai. But unfortunately, time is over. I just like to give my comments only for a couple of minutes or 3. I have my post-graduation about 46 years back, and my undergraduation ophthalmology 50 years back. Right now, what I am saying is a very shiny part of the postgraduate students as well as the undergraduate students. 70% or more are myopes. They like to read very much disciplined. Unfortunately, communication skill is very limited. Don't like to talk with anybody very much. Don't like to communicate with the patients because they are myopes, they are introverts. On the other hand, the dark side, just to recapitulate the words of my great teacher who is still alive in Kolkata at the age of 103 years and still practicing medicine, Emeritus Professor Manikumar Chhetri sir. He told all of us in his first clinical class in medicine, patients are the pages of the book. But today, even undergraduate or postgraduate students, they don't like to examine the patient. They don't like to go to the patients, but like to read very much. Because from their very KG class, they are all being acquainted with all entrance exam, starting from their high school level, from their pre-medical, medical, postgraduate, everywhere, only reading. That's why what we saw during taking this examination, whether in undergraduate and postgraduate, all of you will admit that if you ask them to show any clinical method, that's very difficult. But any theoretical part, they can utter thousands of pages. The second interesting thing, what we can never think of, Professor Vinita Singh and everybody are there, in our day, just after post-graduation, we are very much confident to have our own private practice or to do any OPD, outdoor, any charity hospital or government hospital. But nowadays, no postgraduates are there enough even to go on a single-hand practice or anything. All these things we have to think of and we have to prepare ourselves. For this, we have prepared the Forum of Opthal Teachers of India for the first time, and we like to include all the retired as well as ongoing, not only the professors, any lecturer, assistant professor, equivalent above in that group. And we are very much, right now, around 1,000 have joined. And we are very much optimistic to have more than 4,000 within coming 1 year will join in this group, and we can discuss many more. And discussion will be mainly focused on an uniform curriculum all over the country, uniform logbook all over the country, and the most important thing, by the name of PG education program, PG course, PG training, those who are not at all teachers, giving some guest lecture or anything, but we the people who are nurturing from the UG to PG, we have to be taken into account, and our words should be taken into account. Then and then only the PG training course will be an effective one. Thank you very much. Please keep in.
Thank you. With your kind words, now the session is over, and I request all the panelists and the instructor and co-instructor to have a photograph together. Oh, okay, ma'am.
Thank you so much for initiating this forum, which is very much the need of the day. And for that, I congratulate Dr. Samanta. And this question of uniform logbook, uniform training, see, we have institutions at the top end, and we have institutions which are not so well equipped with teachers and infrastructure. But we do need to strive for a uniform training and teaching program. And with this, two things have come to my mind. One was that why are we having, what is the, diploma has been almost finished. There are only some places where diploma is there, it is not there. Now we have DNB and MS, and both are giving same training, both are having the same post-training eligibility for various jobs, teaching as well as non-teaching. Then why should we have two parallel courses? What is the advantage? I think this is a big question which we should try to solve. because that it creates nothing except that there are entirely two different streams and the training programs which are trying to achieve the same thing. We are giving them similar cognitive skills, similar psychomotor skills, and similar soft skills. So why should there be a difference? And as far as the training of soft skills is concerned, it is very recently, being taught everywhere: teach attitude, teach kindness, teach communication. Fine, but I always emphasize that the student learns more by observing than what we teach. So we have to be more setting examples rather than teaching them attitudes and soft skills. But I do not deny that we have to ensure that we have that incorporated in our evaluation technique. This subject is endless and the time is short, so I will stop right now. And I congratulate Professor Samanta for taking needed initiatives, and I think we will go ahead a long way with him.
Thank you, ma'am. At the very outset, I must compliment all the speakers. They were very good, and it was a learning experience for all of us. Now, I just had a point which I wanted to actually put up in front of the House for discussion. The topic's term was a pragmatic approach to teaching and learning or evaluation of residents. Now, pragmatic is realistic. Realistic, what exactly is the reality today? Well, I was involved in this SSTC for the last couple of days, and I have been dealing with a lot of residents and post-resident young MS graduates, and I was quite shocked because there were times when final year residents had not even touched the FICO machine. There were people who had finished MS and they had not touched the FICO machine. They were just doing the initial steps of SICS and all. Now, I do not blame them. And I do not blame the consultants, and I definitely do not blame the institutes, because the last couple of years have been horrible and traumatic for all of us consultants, for the residents, and for the entire world. I know Dr. Shiraz did mention some. Okay.